Hello dear doctor, my name is Dr. Sanjoy Ray and today I am going to make a video on the burn and this note made with the help of many burn related topic, especially the Parkland series. A few days back, the capital city of Bangladesh, the Dhaka, there is a plane crash on a school building and the country observing a great loss. So with praying for the deceased soul, we will go through this burn topic. So chemical burn types are burns caused by chemical, electrical, and flame. So in case of a chemical burn, we need copious amount of fluid by tapping water, by running water. So it needs copious, immediate, profuse irrigation, especially by running water with the tap. In case of electrical burn, the most point to be remembered that the issue here is that electrical burn itself are always much bigger than they appear to be. Sometimes in case of electrical burn, we can identify just a small burn on the skin. But the issue behind this burn is more than what we see. There is a deep tissue destruction and the patient will require extensive surgical debridement. And it leads to tissue destruction with subsequent myoglobinemia, myoglobinuria, and in some cases it may lead to renal failure. So patient needs a lot of IV fluids, diuretics, osmotics, especially mannitol, and alkalinization of the urine can be done with infusion of sodium bicarbonate. Another one is flame burn, which may occur in case of indoor burn or outdoor burn. In case of in our case, that is aircraft crash on the school building, most of the burn are indoor burn, as because more than 100, 2 or 300 students, kindergarten and school students are in their class. So in case of indoor burn, there might be two issues. Number one is carbon monoxide poisoning, and another one is respiratory burn. Respiratory burns means that a smoke inhalation producing a chemical burn of the trachobronchial tree. So for the first issue, that is, if you suspect there might be carbon monoxide poisoning, so check blood level of carboxyhemoglobin and put the patient immediately on 100% oxygen as early as possible, and subsequently patient may be referred to the hyperbaric oxygen chamber. But in case of second issue, what in our case, in the country facing this patient with respiratory burn, bronchoscopy can be done for diagnosis purpose, but in obvious case, bronchoscopy usually not needed. Now we are on the stage of management. At first, what of the burn? It is respiratory support needed with intubation and use of respirator. Open space burn. In case of open space burn, respiratory burn is not the issue here, but here usually circumferential burn occur, and that may lead to, if it occur around your chest, so it may lead to respiratory difficulty, vascular compromise for the limb burn if it occur around your limb. And the later one, the leathery scar can occur that will not expand, while the area under the burn will develop massive edema and the circulation will be cut off. So management in case of open burn, for the limbs, compulsive monitoring of Doppler signal of the peripheral pulse and capillary filling. We must go for a Doppler signal study. And escharotomy at the bedside at the first sign of compromised circulation. And in deeper burn, fasciotomy can be done. And for in case of chest wall injury, respiratory impairment if occur, emergency escharotomy needed. So type of burn with fissure: second degree burn and third degree burn. In case of second degree burn, most important feature is it is painful, having blister and moist. But in case of third degree burn, it will be painless, as because the subcutaneous nerve endings will be burned. So it will appear as anesthetic, leathery, and whitish. So most important part of management is fluid management. We thought sometimes we get confused. The main point we should know that in case of burn patient management, for the first instance, blood transfusion is not needed. So no need to think about the blood transfusion. The point to be remembered and to be emphasized that fluid is the only thing that is needed to manage your burn patient. The what type of fluid we need actually, it is the only ringers lactate without sugar. So we will choose the fluid only the ringers lactate. And in case of adult patient, the infusion rate will be roughly 1 liter per hour. But in case of child patient, it is around 20 ml per kg body weight per hour. That is the bolus dose in case of child patient. But in case of adult patient, it is 1 liter for the first hour. So you should go with the higher infusion rate, 1 liter per hour. Now there is a special formula for burn patient fluid management that is called a Park formula. We know all. It is a formula that calculates the total amount of fluid needed for a burn patient. It has two components. The first line, that is, it is the amount of fluid that is needed to treat the burn itself. And second line is the fluid that is for our maintenance on daily basis. So these two components as a whole, it is Park formula that gives us total amount of fluid needed for a burn patient. So it is a 4 multiplied by body weight in kg multiplied by percentage of burn area, and it is the total amount in ml milliliter of ringers lactate for burn plus about 2 liter of 5% dextrose in water, that is 5% DA for maintenance, mind it. And this is actually for uh, adult patient, it is 2 liter 5% DA in water. So now it is the total amount of fluid calculated by the Parkland formula. Now how we will infuse this fluid? At day 1, okay, in the day 1, we will give half of the fluid first 8 hours, then the second half in the next 16 hours. Total fluid is by these two lines, and the first half in the first 8 hours and second half in the second 16 hours. So it is the day 1. Day 2, about one half of the calculated amount is needed. That means if the calculation gives us about 5 liter for the day 1, in day 2 we will need only 2.5 liter of fluid, and is the time when colloids should be given if we elect to use them. So colloid, if needed, we can give in day 2. Now it is day 3 when there should be a Briggs diuresis and no need for further fluid infusion. Mind it, most important. And there is a case scenario like one post burn day 3 when the IV fluid have been discontinued, as we know, and patient having urine output, heavy urine output about 270 to 350 ml per hour, heavy diuresis, and we easily be confused that as because there is heavy urine output, so should we go for more IV fluid infusion or not? So in case of burn patient in day 3, this breaks diuresis is usual as because it is expected. Why? Because fluid is coming back from the burn area into the circulation. We know in case of burn, extravasation of fluid from the vascular system into the extravascular system as because there is huge edema around the burn. So the fluid extravasation occurs during the burn and subsequent periods. But around the day 3, this extravasated fluid goes back into the intravascular compartment. So intravascular compartment get expanded, and if renal function is quite normal, urine output will be increased obviously. So the patient does not need more IV fluid to replace these urinary losses. So in case of sile, what already I said, in case of sile, if asked for the rate in the first hour, it should be 20 ml per kg. But in case of adult patient, the first hour means 1 liter in the first hour, maybe in the subsequent hour also. But if asked for 24-hour calculation, the formula calls 4 to 6 ml per kg per percentage of burn. It is the children case. So now, what are the other modality of management of these type patient? First of all, tetanus prophylaxis needed. Then a suitable cleaning and use of topical agents. The standard one is silver sulfadazine. We know, always you remember the silver sulfadazine for topical management. And the burn around the eye, we should cover the burn area with triple antibiotic ointment having triple antibiotic. And the pain medication obviously should be given by IV, prazolam, morphine, or centrally acting agents. After the initial day 1 or day 2 of NG suction, in case of burn patient, in the day 1 and day 2 usually need NG suction. And following this NG suction, we should go for intensive nutritional support with NG tube or orally if patient is able to take oral food. And the food having high calorie, high nitrogen, that means heavy protein should be given. After about 2 to 3 weeks, we will go for graft. Now, exception, in case of less extensive burn, that's burn less than 20%, the patient can be taken to the OT room, that is operation theater, and excised and grafted on day 1. Usually, we place the graft after 2 to 3 weeks for heavy burn, but it is an exception where sometimes in less than 20% case of burn patient, we can go for first setting excision and graft on day, and it save a ton of money. So costing may be minimized by first setting grafting. So this is all, and the last one, it's a wired scenario. Suppose a toddler is brought to the emergency department with burn on both of his buttocks. The area are moist, have blister, and are exquisitely painful to touch. The parents report that the child accidentally poured a pot of boiling water over himself. So, is it actual scenario? No, it might be case of child abuse because the burn are on both the buttock only. So thank you very much. This is all about burn from my notes. If you need any further assistance or if have any query, you can put your valuable comment on the comment box. Thank you very much.